that they still say no. Like, come on, how could this be? And why do they still sometimes say no? Because a lot of times we're missing this third area over here, which is who is the patient as a human being, part of our comprehensive exam. It is actually when we combine all of these, our clinical findings, who our patient is, and what optimal looks like, I would tell you that we're going to start doing dentistry that is appropriate for our patients. So part of our findings actually on our comprehensive exam, and this is not a bait and switch, this is part of it, so stick with me here for just the next 5 or 6 minutes, is that where I'd like to start with tonight for our comprehensive exam for the new patient flow and the practice might be a little bit about the patient. If when they come in, you said, you know what, before I set you back to take a look at that broken tooth, those red gums, the chip that you feel, the rough spot on your tooth, talk about your headaches, talk about your clicking joint, look at your smile, whatever they came in for. What if you said this? What if you said, before I set you back to take a look at that, is it okay if I take just a few minutes to get to know you as a human being? I'd like to take some time to get to know you. Just a few minutes. Is that okay? But we have to do it intentionally because we do have a business to run here, don't we? We can't take all day. And so if I was your patient today and you said, Kevin, tell me a little bit about you. You're new because you're new to Seattle. And I said, oh yeah, I came to Seattle from the desert, believe it or not. And I moved here in December. On December 13th last year, I drove into town from the desert. But man, did I get out and enjoy the snow. I missed these trees and through here. And when summer came, I got to tell you, I was out there. And I loved every minute of summer out here because I was back with the trees a little bit. And it's interesting, I have a connection with Seattle because I started some of my deepest learning, as Dr. Hess said, when we started back in the very early 2000s, I think maybe it was 99 or 2000, when I was driving up here from Portland to learn from Frank Spear. So I have this connection to Seattle, but I'd never lived here before. After I went through and learned a lot with Frank up here in Seattle, that was when, as we talked earlier, that in the early 2000s, I went to Pankey. And I share this with you because education is really important to me. I like to know my craft a little bit. However, integrating it was not always easy for me. So it was when I went to Pankey that I really started to feel a sense of community. And I was in my first, what I would call real study club, with people from all across the West Coast and into Canada, into BC. And in fact, this is actually a photo of my study club outside of Tofino, outside of BC when we went kayaking together. But you know what? It wasn't just fun, it was deep learning. And it was here that my practice really started to change. I started to notice a difference. My patients did, my colleagues did. And in fact, that's when I got asked to start doing some teaching, both at the dental school and in study clubs, like for the Oregon AGD. I did a study club way back in the day and and I started speaking at other study clubs. And as we talked earlier, because I like to sort of follow my passion, that's what's led me to Seattle, believe it or not. I was about to start this business, and that's when I got asked to go be full-time faculty at Spear. And I was down there for 6 years until I moved up here this year. And so it's sort of done full circle, isn't it? It sort of started in Seattle, I went to Spear, and now I'm back into Seattle where sort of my education started. And as we talked about at the beginning, I do have a business, and I spend most of my time now with my business, K Squared, and I'm also starting to do some consulting for HPA, Health Professionals Alliance, and then the Pankey. The other thing I would like you to know about me, since you asked because I'm your new patient, is that I do have 2 kids, because you always ask, and I'm also a grandpa now. My daughter is 31 years old, and I am definitely the best grandpa I know right now and enjoying it. And I do also have a son, because you asked when we were in my new patient exam right now, and we tend to connect. He is 23, he went to U of O, and he still lives in Eugene, but we do a lot of outdoor activities together. We do a lot of backpacking together in Alaska, Oregon, Washington, Arizona, you name it, we love it. And we connect to nature. And I do have a wonderful, beautiful girlfriend, Kimberly, who is Canadian, as Timmy knows. So I tend to connect with you Canadians. And we also have this love for the outdoors and backpacking. So I went through that sort of quickly. Now, if I was your new patient and when you were listening, what were you listening for? Because granted, we're on Zoom right now, so you couldn't really talk back. But when you were listening to me, how many times do you think you judged me? Whether it was how arrogant, how fast, what I was wearing, maybe it was something you liked about me or didn't like about me. But yet, while you were in your brain judging me just a little bit, you were also probably missing the next important thing I was about to say, which could have been about my values. If we had to go through that again, and I won't make you go through it again, and you were not judging me and you were just suspending it, and then the whole time you were intentionally listening for my values. What is important to me? Because we're going to make that connection to me to help me move towards optimal health. But at the same time, you're listening, especially in dentistry, for red flags. And there's really only a couple of them in dentistry. And it really is blame and not taking ownership, right? Oh, that dentist did this to me, or that was, it's not my fault. Otherwise, nobody's cray cray in dentistry, I don't think. People who are in pain have gone crazy because they're in chronic pain. So the only red flags I listen for is blame and not taking ownership. And the last thing that you couldn't do, but with our new patient exam, is to what I call stay in. Oh, I have a black dog too. I love camping too. I love backpacking too. I've been there too. It's like, no, that's not where we connect. Where we connect with our patients is when you were heard and you say to me, wow, Kevin, that sounds like that's really important to you. And I go, oh, so important to me. Wow, Kevin, it sounds like that family is really bringing you a lot of joy as you get into your 50s. Yeah, say more about that. If you stay in the question instead of steal it back and talk about your grandkids, you will find that we really make an intentional, quick connection with our patients that's deeper than just I live in the same town and have a black dog and like backpacking too. So, and right now you're thinking, Kevin, we started this talking about these crazy times. And in fact, these are crazy times. And you're thinking, I can't do this through all of this. I can't, we just need to get to dentistry. I'm exhausted through the mask. Everybody's wearing a mask. I just got to get to dentistry. And what I'm going to almost beg you right now is to take a half a step back and know that more than ever, through your mask, through your N95, through your shields, now more than ever, we need to say to our patients, is it okay if I take just a few minutes to get to know you as a human being and through the mask? So as you get to know about me and listening for my values and suspending your judgment and staying in the question and listening for red flags, what else can we do very intentionally to help our patients move towards complete dentistry in the direction of health? Well, we could, LD Pankey had 22 questions. He didn't use them all. He pulled out the ones that were important. But he knew which ones to pull based on the temperament of the patient and sort of who they were and their values that he was listening for. That's our gift. However, one that I always ask is, hey, is it important that you keep the teeth you have in your mouth right now for the rest of your lifetime? Those answers are going to tell us a little something. This is one that I thought I'd share with you that I routinely share that really helps move the conversation in the direction of health is, have you thought about how you want your teeth to look, feel, and function when you're 75, 80, 85, 90, 105? Because most haven't. And then you get to say, wow, this is my job. And they start telling you about this. And as they're talking to you, these are a couple of questions that I always use. I learned these back in the day from Mary Osborne, Joan Undershoots, so many of my mentors that I use. And before we move on, we say, wow, can you say more about that? Because if you do ask that question, and then you just shut up for a second, they almost always do. And then when you think they're done, they're not done. Because if you ask if there is more, there is always more. So now we're starting to get into dentistry a little bit, and that's just a couple of questions. And finally, before I set you back, I'm just wondering, have you noticed anything about your X, Y, and Z that worries you? Is there anything about and it could be bite, muscles, joints, teeth, aesthetics, the way the food you eat, anything that is a concern for you and the way anything you can come up with. But I use those two words you see in red there, worried or concerned, very intentionally. And you'll see those come into play as we move into treatment planning in the next session. But really, these are the questions I ask. There is one last question that I ask before I set you back. And so now I've got an understanding of who you are. And I say, before I set you back, um, what would you like me to know about you as a human being that you think would help us work better together? Is there anything that you would like me to know about you as a human being that you think will help us work better together? Because there always is. And now, bam, now we are ready to go. We've set the stage, understanding who our patient is so that we can help our patients move towards health, because everybody wants to be optimally healthy. Make that assumption, it's gonna pay dividends more than you know. Why do we make this assumption? Why am I spending these extra 10 minutes at the beginning of our precious time right now? And I will tell you, because we're in relationship with our patients. And our relationship with our patients for years was, which was fine back in the day, by the way, it was tell, sell, teach. Tell, sell, teach, tell, sell, teach. Today, what we know from people like Bob Barkley back in the day is we're going to start to move in this realm. I'm not going to go through all of these tonight, but guided discovery, helping our patients understand what's happening with them as we understand what's happening with them simultaneously. They learn about themselves as we are learning about them. That's guided discovery, so that we can consult with them about dentistry, so that we can coach them. Just like I've hired a running coach and a triathlon coach. It's not like I didn't know anything, but I needed a coach so that we can eventually just facilitate moving them towards optimal health. So we do less tell, sell, teach, more guided or co-discovery, so that we can consult with our patients and coach them to health and facilitate them. That all said, as we are in relationship, I would be remiss if I didn't spend a few minutes, because LD seems to always be connected to good dentistry, I think, and good groups like WAGD and you right now. And that would be, LD had this, what he called this cross of dentistry. It's not a religious cross, it's a cross. And he said, first of all, you have to know your work. Well, everybody on this call knows your work. You do know your work already. And it wasn't easy, was it? Gosh, no. And then we have to apply our knowledge, right? It's like, I could learn about injections and learn about fillings, but I finally had to give an IA injection that scared the crap out of me. And then I had to, put the rubber dam on and actually, use the burr. And that was hard enough. But then LD says, we also have to know our patient. And at the top, we have to know ourselves. And it's when we have all four of these that we really have this reward, whether it be materially or spiritually, in whatever sense it is for you. I won't go into detail with that tonight, because you know what that is for you. However, dentistry is hard. It is for me anyway. Applying my knowledge is hard. But if I pulled, 1,000 or 100,000 dentists, and I said, which of these four do you think really is the most difficult? I promise you the overwhelming majority would say it's at the top of that cross, which is know yourself. So as we help our patients move towards health, doing what might, again, I'll put air quotes around comprehensive exam. One of the things to get to know our patients, as we just talked about, is to know yourself, to put some intentional time into that. And that is my hope for you as well. And I hope to talk to you about that more. So now we've got all of this. We've sort of set the stage for predictable dentistry now. We know our patient, but what is this thing we talk about comprehensive? We talk about this comprehensive exam. Is it that it's patient-centered, health-centered, occlusion-driven, or is it really just this word comprehensive? So we started off with this assumption that everybody wants to be healthy. And now, and we've listened to their values, we know who they are as a human being, but now it's time to set them back and look, we need to assess their current status. And when I say assess their current status, and I'll be really blunt with this crowd tonight, with this group, because I respect you so much, I think I can. I'll challenge you. It's not where do you have decay and what are your periodontal probings? It's just more than that, right? And we know that to be true. It really is our whole system. It's our patients come in asking us to assess them. They're asking us to assess their health, their status, and they may not know that they're asking for more than decay and periodontal probings, but the whole system is made up of joints, muscles, teeth, and periodontum, and they're all connected, as we're going to talk about. So when a new patient comes in, how can we efficiently, systematically start to have this vision of what's going on underneath the patient's skin with the joint, have this vision of what the muscles are doing to affect the teeth and the joints because they're connected, and look at the teeth a little bit differently. Certainly, we're going to look at decay and erosion and periodontal probings and bleeding bleeding points, etc. But we're going to look at the teeth maybe a little bit differently for structure, and also take a look at how the teeth are touching each other and how they're rubbing on each other, because that is the system, right? And so when we talk about the system, I'm going to take just 2 minutes here before we evaluate the system. And let's talk about what a system in harmony really is. Because if we, the dentists here, both the older dentist and the newer dentist, if we can have a common verbiage, nomenclature, vernacular, whatever word you want to use, I don't know which one's the right word because my vocabulary actually is terrible, but it's one of those. If we speak the same language, and our team does too, things change. So let's start to speak the same language. Could we, if we were live right now, or in person, it's a little more fun, but we're going to have fun tonight anyway. It's, you know, if you had to put words to what an optimal system in harmony looks like, what it is, can you both right now, more, I don't want to say senior doc, but, you know, more experienced doc and the associate doc, can you both come up with what optimal looks like for you? Because if we can't put words to it, how can we describe to our patients what it is and help them move in that direction? So for me today, on, you know, in November of 2020, and it changes for me, it has to be because I have this vision in my head. For me, what optimal looks like, starting right now, it would be that I want you to be able to chew the foods that chew healthy foods, which means that your joint has to be able to work properly to open and close your mouth. And the ball has to be able to come out of the socket because it is the only joint in the whole body that the ball is meant to come out of the socket. So my hope for you is, when in optimal, is that the ball comes out of the socket in a nice smooth manner. However, when you bite together, that the muscles on the left work in harmony with the muscles on the right to bring your lower jaw up to your top jaw. And when it does it, that the ball goes back into the socket where it belongs. And that when the bottom teeth touch the top teeth, that all of the teeth touch evenly and simultaneously. Back teeth just a little bit harder than front teeth. And when you move your jaw in any direction, that the front teeth make the back teeth come apart, but in a very smooth, shallow movement, so they're not bumping each other too much either. And that the gums and bone that hold the teeth in are solid and disease-free, so that the teeth don't move around or shift or flex at all. And when we have all of those components together, most of the time, you're pain-free, your dentistry lasts a long time, you look good. Those are all by default. So when I talk about a system in harmony, that's what I think about. The ball comes out of the socket in a smooth flowing manner, but when we bite together, the ball goes back up in the socket. And the muscles on the left work in harmony with the muscles on the right to bring the lower jaw up to the top of your jaw. And when they do, the ball goes back up in the socket and all the teeth touch evenly and simultaneously, back teeth just a little bit harder than front. And when you move your jaw in any direction, your front teeth make your back teeth come apart to protect them. It's their job, but in a real smooth, shallow way. And that the bone and gums that hold your teeth in are solid and disease-free. So that would be but I want both of you, the more senior dentist and the newer dentist, to come up with, what does optimal look like, so that we can share that. Because if we know what harmony looks like, then we will start to be able to visualize disharmony. Because disharmony is really, we only get disharmony because of 3 types of diseases that cause dysfunction. There's a 4th reason we go into disharmony, by the way, and of course that's trauma. You know, if you get in a fight or an accident or something like that, playing on the playground, that will cause you to go from harmony to disharmony. But otherwise, there's really only 3 diseases that will cause you to go from harmony to disharmony. And one is decay. Your teeth are going to rot away so much that they're unrestorable. The other is periodontal disease. They're too loose and unrestorable, like they're not going to do the job they're supposed to do. Or they're broken down so badly and cracked so badly that they're unrestorable. And that disease is called occlusal disease. They'll all move you towards dysfunction. And probably the occlusal disease will do it faster. But what I want you to see as we start to evaluate the system is that it is a closed system. We wish that the whole chewing system was just this smooth flowing wheel, except that the joints are connected to the muscles, and the joints are connected to the muscles, are connected to the periodontium, are connected to the teeth, are connected to airway, are connected to what we eat, are connected to what we do with our teeth. And when one little thing in our system changes, it affects the other parts of the system. So if we affect the periodontium and you get a loose tooth and then it flexes a little bit when you bite together, it's going to affect what the muscles do to try and accommodate and compensate, which is going to affect the joints, which is going to affect the rest of the teeth, which is going to affect the rest of the periodontium. The good news is the body compensates really well. It's an amazing, amazing system. The bad news is the body accommodates very well until it can't anymore. So we have to remember that it's a closed system. So when we start looking at our clinical findings, for me, it's okay. I think about, and this is my hope for you a little bit, is what does optimal look like? Good, I've got this vision in my head. Now, as I start to gather the data, it's not just this boring, let's get through it. In fact, for me, not only do I know what optimal is, and I'm seeing where my patient is with respect to optimal. It's not I'm not finding out how broken they are. I'm just curious, how close are they to optimal? I tend to look at it in the good way. But I'm also thinking to myself, as I'm gathering the data, I'm going to need it to help us what we're going to talk about next time we get together, which is treatment planning. So I'm thinking to myself, I need this data to go in this category. I need this data to go in this category. I need this data, and it's really just 5 categories. So as I'm going through the exam and comparing optimal to suboptimal, I'm also thinking I'm going to use this data in this particular category that we're going to go into. And for me, it's always been aesthetics, function, structure, biology, airway. And this I learned, back in the early 2000s from Frank. I'm also a big fan of John Kwiecien, very big fan of John Kwiecien. And these are the same 5 categories, right? And so as we're gathering data, we're thinking, which of these categories am I going to need this data to put it in? And at the same time, you're thinking, where are you as far as health goes? Is it good? Is it fair? Is it poor? Is it hopeless? It sort of helps you get some structure around it. So as I go through the exam, I'm thinking to myself, what category is it going, and which of these colors or good, fair, poor, or hopeless does it go in? So that's I tend to always combine sort of Pankey, Spear, Kwiecien, and I would be remiss if I didn't bring up Pete Dawson as well. And if you want to have this great, I'm not such an eloquent speaker, and I try and help everybody along. I think I do okay most of the time, but I got to tell you, this book, if you want to have a little more in depth than this webinar right now, but you want to do some reading on the side that won't put you to sleep, believe it or not, and how the system is connected, how it's a closed system. We lost Pete a little over a year ago, and it's still one of the best books out there. So that said, let's spend a good 20 or so minutes here talking about the actual exam and why you would do it. And we can go into more detail next time and looking at time tonight. But for me, when I look at the joints, I think to myself, I would like to have this vision of what is going on underneath the skin. And I can have this vision. It's a best guess as to what I think is going on underneath the skin. It's a great guess, though. And I can do that by feeling, palpating, watching the movement, and listening mostly with my fingers. So let's go over that here for a few minutes. First of all, a lot of dentists, I have to be quite frank with you. When I first started really integrating an examination of the TMJ, I thought to myself, crap, I'm a dentist. I don't even know where to find this darn thing. And the good news is it is the only thing that moves when you open and close, right? And I'm being really serious with you. So because the ball comes out of the socket, when you want to just find it, you just ask your patient to open and close, and whatever moves up there right in front of your ears, you're like, oof, found it, good. And we're going to talk about what that is, though, because we're so used to looking at the picture that you see on the left, knowing that the ball does come out of the socket with the picture you see on the right. And by the way, these illustrations are from Sam Higdon, a really great friend and dentist, brilliant man. But what we're really looking at is actually 3-dimensional, isn't it? So let's look on the left two-dimensionally, remembering that it's three-dimensional on the right. So knowing that we've got the head of the condyle and the glenoid fossa, right? Now, by the way, I don't patronize you. I call it a ball and socket for quick reference, and because that's just the way I use it with patients and dentists for quick reference. But we certainly know it's the head of the condyle and the glenoid fossa is a ball and socket, which in between it has this disc that is non-innervated of fibrocartilage. It's fat in the back and fat in the front and skinny in the middle. That's what I want you to know about that. This disc actually is held on by a little ligament in the back and by the lateral pterygoid muscle in the front. That's the only thing that holds that disc in place. It's tethered. It's sort of, it sits on top of the head of the condyle, just sort of looking down saying, all right, I got this ligament on one side, I got a muscle on the other, and I'm tethered from side to side. The only other thing I want you to know about is that back here, we have what's called the retrodiscal tissue, where you have the blood vessels and the nerve endings. And that's where we get some discomfort back there, right? Because the disc is non-innervated. So now think about that three-dimensionally. We're so used to looking at the right-hand side here that now we start to think about, oh, it's got a lateral pole. It's got a medial pole. The disc covers the whole top of it. It's got a front and it's got a back. And just having that vision helps me now as we start to do the exam. So the first thing when I do the exam is I'm feeling the lateral pole, right? I'm feeling just that outside with my finger. And I'm asking, do you have any tension, tenderness, or discomfort? I'm really just feeling for inflammation because inflammation tells me something, doesn't it? So I really am mostly around the lateral pole, and we can get to the back side when we do our in-person workshop. We'll do it a little bit more, but I'm looking for inflammation. But then I'm actually I'm gonna listen. While my finger's there, I'm gonna feel and listen for joint noises. Well, what are noises? Most people are so afraid of them. This is a video that we will use forever because it's still one of the most brilliant. And this is a cadaver. And what you're seeing here is as the ball comes out of the socket, the skinny part of the disc stays on top and the disc travels with it. You can see the ligament in the back. That's a quiet joint. It happens to be dislocating a little bit because it's a cadaver. So it's subluxing a little bit as you see right there. But regardless, it's a nice, smooth, quiet joint. So when we talk about joint noises then, I'm going to ask you to stick with me for a minute that this is what most joint noises are. It is when you bite together, a little piece of the disc comes out as you see there. And then when you start to open it, pops back on. You're like, sweet, man, stay right there. You're where you belong. You finally got there. I hope you stay there, stay there. Oh, bummer. Yeah, you didn't stay on. And then sometimes you got to push like heck to pop on. And you're like, whew, baby, you worked hard that time. But at least you're where you belong. I hope you stay there. Hey, stay there. It'd be better if you stay there. Oh, bummer. You popped off again, right? But the good news is when I feel it pop on, guess what I know? It's where it belongs. And then it stayed there for like 90% of the time. I'm like, that's good news. You stayed there for 90% of the time. So when we talk about what's going on underneath the skin, you can already start to have this vision of what's going on. And it's never the whole disc. What you see on the left-hand screen there is when we think three-dimensionally, that little pop is oftentimes just a little piece of the lateral pole. It pops on and we start to open, and sometimes it just oozes off or barely pops back off when we close. And sometimes we hear it's a bigger pop maybe, and it's a little farther down. And you can start to have this vision of, ooh, that might be a little bit more of the disc. And it was a little farther down. And it took a little more work to get on. So at least it's an educated guess as to what you think is going on underneath the skin. I'll challenge you here. You like a quiet joint. I will tell you the temporomandibular joint on the left is really quiet, silky, smooth, baby. No clicks or pops here. So is the one on the right-hand side. No click or pop there, is there? Because the disc is off. So it's not so much being afraid of noise. Noise helps me understand what's going on. And so then you're like, well, Kevin, the one on the left here, or the one on the right, it's not popping. It's not healthy. How would I know? Well, I tell you, because now we watch our patient. We watch our patient open and close. How is the hinge actually working? Does the jaw deviate to the left upon opening and then finish back in the midline? Or does it deviate to the right and stay to the right, but then do this crazy little S curve upon closing? Basically, it's just a quick look at how is the joint, how is the hinge moving as it opens and closes? Because maybe it's quiet, but man, it's moving all over the place. Why would it move all over the place? Because the body is awesome at compensating and avoiding things. And so when we have this vision, now you can start to imagine that as we open and close, and if it deviates to the left or deviates to the right, is it moving, is one side of the disc holding it up a little bit, and then it has to play catch up? Or is it anatomically different from side to side? Or is it both of those? We have this great, great educated guess by doing our exam, the examination of our joint that I just described. The other part of the exam that I would be remiss if I didn't bring up tonight of the joint, of the temporomandibular joint, is what we call a load test. And the load test is actually shoving the ball up into the socket. And I mean, hard, right? I would love to do it as hard as I really could, because that disc is not innervated. And if the disc is in the right place and we shove the ball up into the socket, it should be completely pain-free because the disc is not innervated and it's just the head of the condyle and the glenoid fossa. So we're going to do that. But what I want to bring to your attention tonight is when we do load the joint, where are we really loading it? It's not straight up, because when we bite together and load the joint when the ball's in the socket, we are really loading it more towards the medial pole, because that's where the pressure is when we bite together. I tell you that because when we do the load test, what we're really getting some information, right? Our best guess as to what's going on underneath the skin is the disc in the right place when we bite together, at least on the medial pole. So you can start to visualize that. Hey, it clicks a little bit when I open, but it's probably just the lateral pole because I loaded the joint and I shoved the ball in the socket and it didn't hurt, which makes me think that the medial pole is probably where it belongs all the time. It's a best guess, but it's a really educated best guess. So the good news is to help load the joint, we actually have a cool technique because we want to shove the ball up into the socket in the direction that the temporalis and the masseter are already going. So when we do our class, our live class, we'll use a leaf gauge and demonstrate how to shove the ball up into the socket to test that in a real efficient and a predictable manner. So when we do a load test, one of the two things we would be looking at is there pain? And if there's not, that tells us a lot about the disc is in the right place, at least on the medial pole. You can see from the beautiful illustration on the right that one of the reasons it might hurt is if the disc is off and we're now squeezing into that retrodiscal tissue. So right now, I want you to think, wow, if we just go through this in a real systematic manner, we certainly can have a best guess as to what's going on underneath the skin, can't we? A real good guess. And that's what we want to start with as we do our comprehensive exam, because it's connected to the rest of the system. Now, when we talk about the rest of the system, remember, we are going to do an examination of the muscles. And maybe some of you in dental school were like, oh, these muscles, we just did it to look good. We did it because we wanted to be comprehensive. I didn't even know what I was doing. You are no different than most of the people out there, and that's okay. What we're going to talk about tonight is why should you do it? Maybe you shouldn't do it. And if you're going to do it, what makes sense? And I'll challenge you right here, because the muscles do some different things, right? Muscles in general do different things. If you go to the gym and you are working, luckily the gyms are open right now, but most people aren't going, but everybody's got their home gym now. So if you go to your home gym right now and all you do is lift dumbbells all the time and just curls, so your biceps are working your biceps, what would happen to your biceps, right? They would get big because you're working your muscles, they get big. And if I was to come and touch your big old bicep right now, because all you've been doing is curls, and I was using about 3 to 5 pounds of pressure, and I pushed your bicep and it might hurt. Well, 3 to 5 pounds of pressure should not hurt a muscle, unless you've got a bunch of lactic acid in there and it's overworked. So one of the reasons we look at muscles is, are they big or are they small? Because they're always either atrophying or hypertrophying, which tells us how your patient is using the muscles. And if it's sore, it tells us, are they overusing it? Are they going to the gym too much? Or what if you had like a 5-pound dumbbell on your left hand and a 35-pound dumbbell on your right hand all the time? you might have a big muscle on the right, obviously, and a tiny one on the left. And then I would look at you and I would go, what the heck is going on with you? And you go, well, I do this exercise all the time, a 5 pound on my left and a 35 pound on my right. And I go, that's a pretty stupid exercise. It's pretty asymmetrical. Well, think about this now. If we start to look at our patients, think about just the temporalis, big squeezer muscle. It's going to the gym on a regular basis. If our patients are biting and clenching on a regular basis, really squeezing and working the muscles, maybe it's going to be a big buff muscle when you bite on your back teeth. So we're going to ask them to bite on their back teeth and we're going to feel it. Is it huge? Does it flex out? Is it like that bicep? That tells us something. When we use 3 to 5 pounds of pressure, is it sore? Because if it is, it tells us a little bit. Or is one side bigger than the other? And now I got to ask myself, what stupid exercise are you doing that's making one side bigger than the other side? And they're always doing a stupid exercise. Now I'm just curious to find out what stupid exercise that is. We can find out sometimes by looking at the masseter, right? We bite together and boom, does that baby just fire out? Except sometimes what we'll look at is the masseter fires when teeth come together. Wow. So it's a big muscle. Maybe you're really working it. You're going to the gym. One side might be bigger than the other side. You're like, what stupid exercise you're doing? And then when you bite together real slowly and squeeze on your back teeth, does one side fire before the other side? Because I thought we said that in a perfect world, all the teeth touch evenly and simultaneously. And if they do, then I would expect that when you bite together, that your masseters would fire at the same time. And if they don't, I just learned something about you because the system is connected. It's a closed system, right? They affect the other. So that's why we would look at the masseter. Medial pterygoid's interesting. It gets overlooked. I bring it up on it. We're not going to do all the muscles tonight, but I want you to see that there's different things we can look at. The medial pterygoid, it's a big squeezer muscle. And you can see here, it forms the pterygomasseteric sling, right? It's basically does the same job as the masseter. It's just on the inside and doesn't get as much love because it's not easy to get to, except really it is. It's right there where you give your IA injection, right? The pterygomandibular raphe. And so we can palpate that. It tells us a lot about what our patients are doing, how much they're going to the gym, what kind of exercises they're doing. It's a big squeezer muscle. We may as well get to it because we can. The last one I want to bring up right now is the lateral pterygoid. And you're thinking, man, Kevin, I missed this on part 1 and part 2 of the boards. Don't bring this up. It's bad memories. Except that the reason we missed it is because it didn't make sense back then. It's this muscle that runs horizontally. And its main job is to compensate. Remember how we talked about how amazing the body is because it accommodates and compensates? This lateral pterygoid is your workhorse for accommodating. It is the one that pulls the ball out of the socket to get more teeth to touch when all the teeth aren't touching evenly and simultaneously with the ball in the socket. When things are out of harmony, it's the lateral pterygoid that helps maintain disharmony. It sort of looks like this. Let me back. Here's most of you right now. When you bite on your back teeth, you have teeth touching. Feels pretty good. That's what we call your max miracuspation or your acquired bite. Except to get your teeth to touch in a fairly comfortable manner, your lateral pterygoid is having to pull the ball out of the socket. The green lines don't line up, right? And that's what your body is always doing. Well, the cool thing is we can actually put a little piece of plastic between front teeth. And now you're going to see how the whole system is connected. Now the back teeth don't touch. So the lateral pterygoid goes, well, I got nothing to do right now. I don't need to compensate or accommodate. However, your temporalis and your masseter are squeezing. And what are they doing? They're squeezing the ball up into the socket. So you're actually loading the joint. At the same time, you're releasing the lateral pterygoid. In fact, you have to release the lateral pterygoid to properly load the temporomandibular joint. And the lateral pterygoid is the one other thing that sometimes hurt when we try and load the temporomandibular joint because it almost goes into spasm. It's like, I can't release that fast. So, and we're going to do this in person quite a bit as well. But we want to do this very efficiently because we've got bills to pay, right? We've got things to do. So finally, the other part of the system we can look at, we've looked at joints, we've looked at muscles, and then we can look at teeth. But how do teeth come together? So we can ask our patients to bite together and grind to one side as far as you can go, and grind to the other side as far as you can go, and grind straight forward till the edges of your teeth are there, and even past it if you want. And we could actually have some articulating tape in there. And if I put red articulate, this is Madame Butterfly silk. If I put red Madame Butterfly in and I had you go side to side and front and back, and then I put green in there and I just had you tap, tap on your back teeth, tap, tap. In a perfect world, if we had to have this vision of what optimal is, and we're going to have a whole a whole part of this on occlusion, but right now this is part of our exam. How are the teeth doing right now? How are they starting? Because I thought the front teeth were the ones that were supposed to disclude the back teeth. And if I see red on back teeth, I'm thinking to myself, those squeezing teeth in the back are trying to do the job of a guiding tooth in front. That's probably not a good idea. Or when I see green harder on certain teeth than other teeth, I think those teeth are definitely not touching evenly and simultaneously. And where are those green marks? Are they on inclined planes? Are they on cusp tips? So we can just take a quick look. How do we think the teeth are doing? And if you want to take a quick look, now you can start to appreciate something like a T-scan that like really gives you the details, but I don't think we really need that right now. You can. I think that what my goal for us and for you right now is to actually think about, wow, what's going on with the joints? What's going on with the muscles? How are the teeth coming together and moving, and how is it all connected? My hope for you is to challenge you and say, how can we start to integrate this and help our patients move towards health while we're dealing with everything else right now? And maybe because I want you to keep your comprehensive exam real. I want you to keep it real. So how can we do this? We got to simplify if you want. You can have a 2-hour comprehensive exam and we can ease our way through it. That might work in your practice, and it works in a lot of practices. You can have your patients come through hygiene, but they're still asking you to look at their whole health. Or you can have a quicker, more, I don't want to say more efficient, but just a quicker exam. Well, how long do you think it would take me right now if you were my patient and I've set you back? So I took my 10 minutes to get to know you as a human being, listen for your values, stay in the question, ask you some questions about health and moving towards health. And then I set you back and I said, hey, what I'm going to do is I'm going to find your joint first. But then once I find it, I'm going to put my fingers right here on your joint and I ask you if you feel any tension, tenderness, or discomfort. And at the same time, I'm going to ask you to open and close. And I'm feeling for clicking and popping on both sides. Is it early? Is it late? Is it a pop or is it a click? Is it gravelly? Is it grady? And at the same time you're doing that, I'm watching to see if your jaw deviates from side to side. How long did it take me to feel for inflammation, listen for clicking and popping, and watch to see if your jaw deviates from side to side? Probably not more than 2 minutes by the time I talked to you about it, but I at least evaluated your joints because it's connected to the rest of the system. If all I do is real quickly feel your two big squeezer muscles, your temporalis and your masseter, and feel how big are they or how small are they? Is it sore? Are they different from side to side? And get into this lateral pterygoid area up inside by where you give your PSA injection and do the same. Just 6 muscles. I mean, there are 3 muscles, but 2 on, one on each side. 2 big squeezer muscles and your main compensator muscle. I'm talking that's less than 3 minutes. And how long does it take me to ask you to bite together, pull your cheeks back with my fingers, mirror, I don't care what it is, and have you bite together and move side to side and just take a look. Does it look like the guiders are doing the job to disclude the teeth and the squeezers are doing their job? Or does it look like the guiders are pretending to be squeezers or squeezers pretending to be guiders? How do I think the teeth are doing right now? Just those 3 things is my hope for you. We can spread it out and look at it and do more co-discovery with our patients. That's great too. But if we're in a hurry, we can certainly start to look at how this system is. So here's what I want you to start to think about as we finish up for tonight is we get to have choices. I can be this guy, this crazy guy, or I can be this guy, Mr. Teacher, who helps dentists move towards health. You see, I have a choice. Do I want to move more towards crazy and be more and focus more on teaching? Or do I want to move away from teaching and be my crazy self? You have that choice. Is it that I want to spend more time in nature? Because we talked about that. Is it that I want to actually relax a little bit more after runs? Is it that I want Kimberly to start giving me haircuts even when it's non-COVID time? Because I didn't mind the bald spot very much. It was okay, and we had a lot of fun. Or is it that I want to spend just more time? You get to make that choice. Where do you want to spend your time? as we finish up for the last couple minutes, and I thought this would be a nice way to challenge you at the end of our first night together. There's a guy who I respect so much, an author, Otto Scharmer, who wrote Theory U, and then he co-wrote Leading from the Emerging Future. He works at MIT. He runs the Presencing Institute. He is a global change agent, one of the most brilliant people I've ever had. I've luckily ran into a lot of brilliant people, but you know, basically, when we talk about his Theory U, the thing I want to see you here, we're going to look into it in detail in just a second, but you get to do this. You get to prototype the new. You get to change your practice in a way that is appropriate for you and the dentist. Dr. Hess, when we started, he said, man, there's already some associates who aren't having fun with their dentist after all these years. They were looking forward to it. You can co-create and even prototype the new. But here's what Otto says that I want to share with you tonight. So let's draw a U here. And when we draw the U, we actually, Otto says, and it makes so much sense to me, and it does for everybody, when we think about it intentionally, we actually have to, when we bring an associate on, or we're changing our practices or moving more towards comprehensive exams or a little bit of everything, we have to download past patterns. We've got to come down the U and sort of suspend for a second there, download past patterns and just hang. And what that takes is, as Otto says, is an open mind. And as we come down the U, then we get to see with fresh eyes, because we've suspended and have an open mind. We see with fresh eyes, and then we get to redirect. But to do that, it really takes an open heart, compassion for ourselves for sure, and compassion for those we're working with. And as we continue to come down the U, we are now, what Otto says, is sensing from the field. We're in it now, because we can now let go. And when we let go, we have to do that with an open will. And then when we come to the bottom, we have to cross over the other side, because now he calls it presencing. We are now connecting to the source so that we can come back up the U and let come. We've let go, so now we can let come. And now we get to decide the type of dentistry we want to do, the type of exam we want to do. We have vision and intention that we can crystallize. And then we get to start doing it, right? We get to start prototyping that with an open heart, right? And an open mind. We get to try it on, but we're not winging it. It's a true prototype with intention so that we can start embodying it. We're like, yes, this is us. This is who we want to be in the practice. And then we are truly performing, operating from the whole. So I thought right now I'm going to sort of tease you for next time a little bit and say that we're going to take all this and talk next time about the way our body compensates and how we're going to use our comprehensive exam to understand that our body does have this adaptive zone. Thank goodness, it's amazing. And we have to know where our patients are starting from. That's why we do our comprehensive exam. Because when we get outside of our adaptive zone, then we move in to the danger zone. And that is when we start to see signs and symptoms, right? Well, when we just did our comprehensive exam, we got to see, is our patient right here in the middle of the adaptive zone with hardly any signs or symptoms? Or are they starting here? Or is their body adapting, but there's still no signs and symptoms, but things aren't, you're not sort of optimal, but you're doing okay, but there's no signs or symptoms? Or are they right here? Are we starting to see signs and symptoms? Are they beyond their threshold of adaptability? And we're starting to see signs and symptoms. So I thought what I would do, Timmy, is leave it like that for tonight as a good starting place, because I honor everybody's time, and come back and because everybody's, it's the middle of the week and everybody's got to have their evening. So I didn't want to bombard too many people's time.
Thank you very much. I think that's a great kickoff. I have a few questions that were sent to me via different means here. So without getting too deep into the weeds on these ones, first question was, in dental school, we were taught to plan every patient comprehensively. In my new practice as an associate, everything seems to be single tooth dentistry. What are your thoughts?
Yeah, that's a great question. And my thoughts are, as I started this, is that every patient wants to be optimally healthy. And as we'll talk about next time, the beauty of systematic treatment planning is we get to have this vision of what optimal is so that we can at least have that conversation. And as you'll see in the next couple of webinars, we get to help our patients move towards optimal. in a way that is appropriate for them. So I'm okay doing one tooth dentistry. I am, as long as we know that it's part of the bigger picture to help our patients move towards optimal health. So there's some ambiguity in there. What I don't want to do, and this will be the last part of my long answer to a short question, is my hope for all of us on here is that we do our best not to put the tooth back in the situation that caused it to break down in the first place, right? And we're going to talk a lot about that, but that's all in that question right now.
Okay. My young associate does not see the value of joining the ADA, AGD, or study club. What can I do to motivate them?
I like that one. That is just like our patients, my friend. And our patients also don't do dentistry if they don't see the value in it. Right. But our patients are different. That's why I say listen for values. I can't help my patients move towards health if I don't see their values. So we take a step back with our associates and our team members, just like our patients. What is important to them? How do we help them see the value in study clubs or AGD or ADA? Because their reason for it is probably different from yours, and that's probably the disconnect. And that's the same with our patients as well. So we have to listen for their values and help them see the value in it, and then they will join study clubs and AGD and ADA.
I'm going to be amazed if you can answer this question short and sweet. Sometimes bite guards work and other times they don't. Why?
Yeah.
I think that's probably...
We have a whole webinar on appliance therapy and occlusion coming up. And sometimes they work and sometimes they don't, because we don't know why we're putting them in there. I give you the short answer. We don't know why we're using them. We didn't really evaluate why we're putting a piece of plastic in between their teeth. And maybe we've misdiagnosed and we've been misled.
Okay. I love this question. Should I buy a cone beam CT?
I get that question a lot lately. And years ago, my answer was, gosh, I don't know. It really depends. And it still is. It really depends, except that with complex dentistry moving into the digital era, it's going to be just like radiographs if it's not already. And I know it's your money and it's easy for me to say yes right now, but my answer is it's going to make sense to you. You're going to see the value in it, so you may as well start saving your money now.
Yeah. For those of you that are new to cone beam CT and are thinking about it, I believe December 11th, Dr. Robert Timothy is going to do a cone beam CT course for us. It's hands-on. You can do it hands-on virtually. And then he is also going to do that same course on the Saturday for all our University of Washington AGD student chapter members as well. So there's an opportunity there if you have an interest in that. And I think the costs are fairly low. It's real easy to get you the files, the Plan Mecha viewer and that, so you can follow along. Mm-hmm. Here's one that's near and dear to my heart. Botox. Is it helpful at TMJ? It's yeah. That's
we've got Dr. Hess here. The answer is an obvious yes when it's appropriate. However, for me, I'll give you the short version of that one. Yeah, because that's we don't want to put band-aids on things. I want to help people get better long term, not just put a band-aid on something. But when it's appropriate, as you know, Timmy, yes.
And it is not the first line of defense against temporal mandibular dysfunction. All right. And finally, Lucia jig versus leaf gauge for load testing. Ooh. Which one's better?
Nice. We're going to look into that a lot next time, but both are great and both have their pros and cons. The Lucia jig is, people worry about a leaf gauge distalizing. We can talk about that a little bit next time. And it certainly can distalize if you tell them to squeeze so damn hard, but we don't do that to load the joint. But a Lucia jig certainly cannot, or an anterior deprogrammer cannot, but they both work. They both work great because you're using the temporalis and masseter to shove the ball up into the socket. So whatever one you happen to have out is appropriate to load the joint.
Okay. And then we just got one last question come in. How often do you recommend a sleep study?
Oh, geez. I recommend a sleep study when it's appropriate. And I'm not being patronizing or too ambiguous. it's when we do our exam, and again, you're asking great questions that are coming down. Our exam is going to help us decide what the next appropriate step is. And sometimes it's an HST, sometimes it's a high-res pulse ox, sometimes it's a PSG polysomnogram, sometimes it's a record your snoring. It's what is appropriate for each patient. So great question, and it's often and yet not always.
All right. Well, fantastic. I guess we'll tackle more of these questions in depth in future webinars and the hands-on. I'd like to thank you, everybody that joined us this evening. Please invite your friends, your colleagues, your young associates, everybody to join us. And if you have questions that you'd like to see us address in future webinars, please send them our way. We are going to put this webinar together, just edit it down a little bit. Keep in mind that you are receiving complimentary CE through the Washington Academy of General Dentistry for these webinars. So we appreciate you joining us. We'd like to thank Omni Practice Group for being our major sponsor of this event. And unless Dr. Kwiecien has anything else tonight, let's leave it at that.
Yeah, sounds great. I look forward to being with everybody next time.
All right. Thanks to all our friends out there. You take care.
Thank you, Dr. Kevin. Thank you, Dr.
You're welcome.
Hess.
Thank you, Valerie.
See you, Val.